Hello everyone and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinions and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Saba Balasubramanian, Adam Haig, Ben Wood and Josh Lau, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. So today, for the first time, we're going to talk about a qualitative research paper. You will shortly hear all about it. We are sorry that after teasing you for a bit, we were not able to bring you Professor Wild talk on mixed methods research. This was due to a technical issue. We will make sure we reschedule this session for the next few months. We will be having a little bit of a chat about qualitative research and philosophy of science after the paper presentation, and I have left it there for you to listen to as it brings up a couple of very interesting points. Stay tuned for more special guest sessions. We will have Professor Rosins from Tel Aviv in July, and I will leave you to the paper.
We are going to talk about a paper slightly different from usual. It's the first time we talk about a qualitative research paper, and it's the first time, for whatever reason, that we talk about a COVID-19 paper as well. So two firsts for tonight. As you can see from the title, this is a qualitative study exploring how surgical teams mitigated the risks of COVID-19 in the early phases of the pandemic. It comes from a mixture of researchers from Bristol, some from Cambridge and some from Leeds as well, and is published in BMJ Open just this month. So Maria's going to tell us a little bit more about the background for this paper.
Hi guys, I'm Maria. So COVID-19, obviously everyone knows unfortunately what that is. However, it was something that was on the news and then all of a sudden it was all around us in many ways. There was no time for research and things had to be put in place very quickly with very different circumstances evolving around everyone. Operating theatres are high risk places anyway in their nature. However, there were many other risks involved when it came to COVID-19, such as social distancing. You can't social distance from your patients as a surgeon. You can't social distance from your team, your scrub nurses, your assistant, and also there's aerosol generating procedures in theatre, and obviously that also puts a lot of people at risk who are working in theatres in a multidisciplinary environment. So there were also many different managers involved in making protocols, which meant that as frontline staff, we had to deal with, well, my nursing manager says this and my ODP manager says this. So in many ways, there were too many cooks, spoil the broth. I think we had to make sure that multiple people were happy and coming up with one guideline. So it was also a time where people were worried about taking the virus home, which is something that before COVID-19 was something that I didn't really think about before I went to work every day, but that suddenly became a big issue when COVID came. And also this paper is in what way people are making sense of what's happening around them. So back to Gio.
Yeah, so thanks, Maria. In this context, the aim of this paper was basically exploring surgical teams' experiences of current practices during the pandemic and understand two things: how they perceived the risk of COVID-19 in surgery, and the word perceived here is very important, as we will see, because of the stages of the pandemic where this paper was sort of generated, and how they mitigated the risks that they perceived were there. Just a brief highlight of the qualitative methods that are applied to this paper. Now, the authors use semi-structured interviews, and a variety of methodologies are there about interviews and how to conduct them. They are recorded and transcribed. Authors then and researchers go through the transcriptions of the interviews and identify codes. Now, this is a definition of coding. It comes from Gibbs. Gibbs is a big name in qualitative research and in medical education research as well. And basically, coding is a way of going through a text and indexing and categorizing it in order to define a framework or themes or ideas that are coming out of it. The authors then go through the transcriptions again and the recordings where necessary and identify a variety of themes with a comparison and a contrast approach. So basically they identify a set of themes that are in the background and potential contrasting themes that are emerging in order to highlight even opinions that are relatively little represented in the population. Overall, this is a very good example of grounded theory. So basically, your theories and your information comes directly from the data. You are not approaching your research starting from an assumption. You let the data drive you to your conclusions. And Maria's going to go through this methodology in a little bit more details, particularly as applied to this paper.
So just wanted to highlight, thanks Gio. First of all, this paper the interviews were conducted between March and May 2020, which was during the first wave of the pandemic. So this is a qualitative study, so it's a little bit different to how I've conducted studies in the past and also how I've read papers before. So it's a few things to get around, if that makes sense. So they sort of used a key informant to sort of do their interviews, which means that they asked people who they thought were either representative of a group of people so that they could sort of broaden the ideas they were getting, if that makes sense. They used a snowball sampling, which is where you sort of just ask your friends to do the study or the people you work with, and then they suggest other people who would be good to do the study. And that, in a sense, is how a snowball grows. As it rolls down a hill, it just sort of recruits snow as it goes along. So that's why it's called snowballing. However, the people that were conducting the interviews had quite an open script, open-ended questions, but they did have a script that they followed. And they used reflexivity, which is where they sort of think about how they're asking the questions and make their own reflective notes as they go along. And then they can change the way they're asking the questions if they feel they need to. So they can change and alter the interviews as they're going along, which has its own benefits, I suppose. However, they focused mainly on the risk that people were feeling, both for themselves and for other people. So when we're talking about others, that's for their colleagues and also the patients as well. But this wasn't a patient experience or anything. This was just about healthcare professionals in this survey that they did. So back to Gio.
All right, so let's start digging into the results. So as you can see, they had 43 participants in total. And as you can see from this diagram, the distribution of people involved was quite, you would say, uneven. There were 34 surgeons, 5 anaesthetists, and 4 nurses. But let's have a look at what type of surgeons and what type of nurses they managed to recruit. The vast majority of surgeons involved were general surgeons. I guess we are reasonably easy to come by, followed by ENT surgeons. Pretty relevant group in this context, because obviously they are exposed to AGPs all the time. There were 5 neurosurgeons, 2 cardiothoracic surgeons, and a lone ophthalmologist contributing to this research. I draw here a list of the nursing sort of practitioners that were involved in the study. And as you can see, there's 1 practice educator, 1 nurse manager, 1 matron, 1 charge nurse. So the vast majority of people in this group are actually quite far away, in my views, from the daily activities of theatres, though they might very well be involved in policy drawing and design. So ball to you, Maria.
Thanks, Gio. So this world map just illustrates where people were recruited from. So mostly you can see it from the UK. However, they did state that they wanted to have opinions from other healthcare professionals who were ahead of the curve when it comes to COVID-19. So that's places like China and Italy and Spain who are probably ahead of us. So that's why you see they're recruited there. Thanks, Gio. Back to you.
Marvelous. So the authors overall identified 5 main themes or codes, I guess. Facing new and uncertain risks, changes to the context of surgery due to COVID-19, innovations within high-risk specialties, aerosol generating procedures, their complexity and risks associated with it, and the uncertainty related to those risks, and obviously adapting to PPE related challenges, which I am sure everyone in the audience have suffered from. So we'll briefly go through these 5 themes, bearing in mind that what we're going to tell you is our interpretation of the paper itself. And if you want a first-hand account, including key quotes from the interviews, you should go through the paper itself. So ball to you, Maria.
Thanks, Gio. So the impact on what procedures are performed, there was a lot of issues around people being able to secure PPE. So a lot of elective procedures were cancelled, not just for the risk, was more to do with the risk of not having PPE as well. So that needs just to be highlighted there, and that's more of a governmental issue. There was less coming through the door, so there was less operating in that way. However, there was a lot of anxiety about catching COVID-19, both from frontline workers and also from the general public, which probably dissuaded people from coming through the door. And obviously there were risks to themselves and risks to others. So this is something that we didn't have to deal with before. So that was definitely something that was highlighted when people were discussing it in these interviews. So back to Gio.
Marvelous. So another very important point was related to changes to the context of surgery. Now, the participants highlighted how theatre pathways were changing quite often, and I'm sure you all remember from the beginning of the pandemic, pathways were changing on a weekly basis, or if not even more often. And a lot of participants felt that ongoing team discussion was an essential component of changes or altering or updating these pathways. And a lot of stress was generated by working with a very limited amount of evidence. Some of, I believe it was an anaesthetist that mentioned this in the paper, mentioned the possibility of using new techniques and innovating in a sort of very fast and very improvised way. And they called it the MacGyver effect, which I've actually looked into and is a thing that has been described in the cognitive sciences literature. Obviously, when you start doing things like that, sometimes it works out, but most of the time it actually doesn't. And that seemed to be the main feeling from the participants in this study. So, ball to you, Maria.
Thank you, Gio. So the high-risk specialties that were identified were ENT, max-fax, and anaesthetics, particularly. Unfortunately, the first death from COVID-19 on the front line was actually an ENT surgeon. So I think that the community of ENT surgeons felt that they needed to step up. So they did things like turned off ventilators to decrease the amount of secretions for a period of time before they started doing tracheostomy procedures. And also both in anaesthetics and ENT max-fax, they sort of prevented their trainees from doing certain procedures such as tracheostomies or intubations, not because they didn't want the trainees to do them, but it was more to do with the fact that they wanted the most skilled person to do the procedure, to one, decrease the amount of time that was taken to do the procedure, and also to decrease risk to everyone else in the room, because obviously the more time you have an aerosol generating procedure going on for them, I suppose the higher the risk is. So I know that was a thing that was going on. In anaesthetics, they also changed the mode of the way that the anaesthetic was given, so they do more local or regional blocks, and maybe I suppose dissuading people from having operations if they didn't need them. Maybe things such as putting people to sleep was done in theatres, not in the anaesthetic room, and they had the 10-minute downtime where just the anaesthetist and ODP were present in theatre, and try to decrease the amount of aerolisation that was happening. So people used full PPE, smoke and filter evaporators. There was mention in the paper as well of using plastic drapes over patients' faces when they were anaesthetised to decrease the amount of aerosol generating particles that were getting through. And small things like writing their names on the top of PPE, because there was no name badges, were also mentioned, just little things to try and help. Yeah, so back to Gio for the results.
Right. So further point, AGPs complexity associated with them, and uncertainty associated with the risks of performing one. Now, a fairly basic question that I think we all asked ourselves at the beginning of the pandemic was, what is an AGP? Now, certain things are quite obvious, like, I don't know, endotracheal intubation, but NG tube insertion went in and out of the list a couple of times, as well as transnasal endoscopy for upper GI purposes, for example. So a lot of recommendations changed throughout the first phases of the pandemic, and that obviously generated a lot of distress. A lot of surgeons mentioned the urgency or the need of interfacing with the community. So basically finding out what other hospitals were doing. And I'm sure we all experienced this firsthand. A lot of our consultants in other fields at least still discuss opinions that they received from a variety of tertiary centers when deciding what to do, for example, in doing laparoscopic appendicectomies, yes or no. And obviously, whenever you're performing an AGP, especially if you're not entirely sure how you're supposed to protect yourself, you feel the risk of putting yourself in contact with COVID, and obviously putting your family in contact with COVID. Ball to you, Maria.
Thanks, Gio. So obviously the way we use PPE before COVID was quite blasé. I think we didn't really know how to don or doff, and these were terms that were thrown at us very quickly. So I think we all had to adapt to the use of PPE, and also when there wasn't adequate PPE, what to do then when we had issues with that. So I think there was a lot of tension between the government and ourselves, and also a bit of anger as well. And I think this was all things that probably in a qualitative study probably come out a bit more than maybe in a quantitative study. But, you know, they're all important points to make as well. So back to Gio, because we're going to, I think it's me actually, sorry Gio, we're going to talk about the limitations. So the limitations in this study was the sampling, I feel. It was this snowball falling effect, which I don't think was great. It was also, just to mention, it was 77% male, which is, you know, it's fine, but they stated in the paper they wanted to make it equal. There weren't really the right number of nurses, I don't feel, in this study, and also there were no ADPs in the study, and they're quite a large part of our MDT within theatres. They talk about the social desirability bias. So this is where people, when they send out a survey, and then the people that respond to the survey, they sometimes think about what the people that send the survey out want to hear. So sometimes things are overly, you know, the good things are overly reported, and the bad things not so much reported, if that makes sense. So that can be quite difficult as well. And also the interviewing period was probably some people may say a bit premature for our peak here in the UK, because in March 2020 I don't think we were experiencing the peak as much as they were in Italy or China or Spain. So we're just going to talk, Gio's going to talk you through the others.
Yeah, so as you can see, we reiterated again, is the sample representative? I think this, obviously the authors do mention it, but I think there are a few issues that they don't highlight very well. The vast majority of people interviewed were obviously surgeons or anaesthetists. So they do sort of have a position of power and responsibility in the operating theatres. And I suspect with the involvement of a certain number of ODPs or people that do hierarchically have a different position in the operating theatres, even simply trainees, you would probably have a very different view. And if any of the recent theories about motivation is true, I suspect a lot of the social desirability that we have seen coming from surgeons probably would not be as evident in interviewing other people. Response rate, they mentioned that they have 9 people that declined, and I suspect this is from direct request from the interviewing group. And I think that this is obviously an underestimate, A, because you can't really track snowballing, and B, because they also use the Royal College of Surgeons platform to advertise this initiative, and you don't know how many people you've reached there. So their dropout rate is actually much higher. And there is a language issue that they don't tackle at all. I am not entirely sure if the number of people that they recruited in Italy or Spain or China, for example, is related to the fact that there was a language barrier and therefore the sample could not be as representative. So to wrap this up, basically the two main themes that emerged from this qualitative study are that communication and teamwork played an integral role in how teams adapted to the challenges of COVID-19. And while there were a lot of guidelines out there that were published very quickly, the perception of the risks associated with COVID-19 and AGPs were very complex and very much context dependent. And I just want to say one thing from this table down at the bottom. I think that the main limitation of this study is poor sampling, but the methods that they use in conducting their interviews and going through the interviews felt to me very rigorous. And this is the end for us.
Right, in the next a couple of minutes, I'll try and give you a rundown of the discussion we had after the paper presentation. A very few interesting points emerged that are worth mentioning. So let's start with a very relevant and very simple question. What is the external validity of a paper like this? Concept of external validity applies relatively to qualitative research. As mentioned during the paper presentation, the researchers here use grounded theory, which basically mean that researchers start their approach to the problem from a constructivist perspective, and they are not seeking a mathematical truth, but they are rather letting the data drive their conclusions. There's a lot to say about the philosophical approach that people have to research, and I have to say so far in CRAMSURG we have perhaps taken a post-positivistic approach, mostly focusing on the data and the methodology around the data, which is definitely a relevant part of research, but a part of it. Can't pretend to give you a rundown of philosophy of science in a couple of minutes, so I will put in the show notes a link to a podcast from Lara Varpio, a PhD professor in the States. And in about 20-25 minutes, she will give you a rundown and a primer of philosophy of science and the core differences between a positivistic, post-positivistic and constructivist approach to science. So to cut a long story short and answer the original question, external validity doesn't really apply to this type of research. To a certain extent, qualitative research does have transferability, provided that the sample was adequately constructed and collected. However, that's not always the case. A further important point from debate that emerged was related to whether we feel that qualitative research has a space in surgery and how likely it is going to become a big part of what we do on a daily basis in the future. So my take on this is that qualitative research does have a space in surgery, obviously, and I feel personally that the best examples of qualitative research that I come across are related to the use of such technique as complementary to quantitative data. And I think a brilliant example of this was the LACES trial, which we presented a few episodes back. By the authors used qualitative techniques to identify acceptability and potential barriers in conducting the randomized clinical trial itself and issues that emerge from the perspective of both participants and researchers associated with the trial. I personally think that qualitative research on its own does obviously have a space in surgery. However, I think that its lack of generalizability and often lack of transferability does limit its applications to a certain extent. But this is just my view of it. And it's perhaps limited by the fact that I personally have never conducted qualitative research as a standalone project.
Can I give a different viewpoint?
Go for it.
I think there's lots and lots of room for qualitative and mixed methods research. I'm just coming out the back end of an MD, which was mixed methods research with Prof Wild, and I think the problem is it's really hard to understand and get your head around it, because we've been fed numbers, p-values, all these kind of things which we're told are really important, but actually it only answers part of the question. Whereas these sort of explorative kind of data backed up by questionnaires and other things gives a very different, rich data, which is more humanistic and presents something quite different. And in particular with sort of patient involvement and patient participation being so important in research these days, I think it's definitely a growth area. And I think it is something which is really interesting, and you'll probably see a lot more of going forward. But I think at the moment it's still quite difficult to publish. Papers are generally much longer. If you look at the word count for this paper, it's much longer because you've got all the quotes and all that kind of rich data, but people just aren't used to seeing it and reading it, and it is harder. But it does add a richness and a tapestry to an understanding a problem in a different sort of way, using qualitative, quantitative, and different methodologies together. I think it really adds to the literature and understanding a topic in a much deeper sense.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.